Good morning. I'm Steve Glassman from the Leatherman Spine Center in Louisville, Kentucky, and it's really a pleasure to be able to participate in this year's Philippine Spine Society meeting. I'm only sorry that I can't be there in person, but maybe in the not-too-distant future. Dr. Andriga asked me to talk a bit today about impact of sagittal balance in adult spinal deformity, and so I'm going to try to cover some of that topic. These are my disclosures. So in about 2006, we published an article that really documented the importance of sagittal alignment on health status in adult deformity patients. The thing that was really different at that point about that data and that message was that previously sagittal alignment had been something that we paid attention to for sagittal deformities, so Sherman's kyphosis or post-fracture kyphosis. But what this data demonstrated was that this was really the dominant predictor of health status in coronal deformity, in adult scoliosis. So that led to the idea that it would be good to restore that alignment, but left the problem that it was hard to know what the baseline alignment would have been in any one individual. And that gap was, at least theoretically, bridged by data from Frank Schwab and Virginie Lafarge that identified pelvic incidence as a predictor of normal alignment. So then over the next 5 or 6 years, we saw very aggressive correction of lumbar lordosis. This is a paper demonstrating the magnitude of osteotomy that you needed to essentially try to correct alignment and lordosis to what we saw as normal based on the pelvic incidence. Well, it turned out that didn't work very well, right? So the idea that if sagittal malalignment is the problem, then restoration of normal sagittal alignment must be the right answer just didn't turn out to be right. And what happened, instead of everybody being good, was that we then saw an epidemic of PJK, where a lot of these people who were aggressively corrected began to fall over above their surgery, sometimes in pretty dramatic fashion. And then, the SRS Schwab classification that was built off this and used sort of as a guide, it turned out it didn't guide treatment very effectively. So people were corrected what looked to be a reasonable amount, and yet they weren't really good. Maybe in retrospect, that should have been more obvious. I think one of the main points is that loss of lordosis is normal aging. It's just what normally happens. And so the idea that it was beneficial to give a 70-year-old the lumbar lordosis of a 20-year-old, maybe it was sort of evident that that wasn't a good idea, but it took a long time for us to figure that out. Now people are looking to use more age-appropriate alignment targets. In all honesty, I'm a little skeptical that that's really going to be a dramatically different ball game, but I guess we're going to see with some time. The other thing was where the lordosis was located. So the easiest place to do these osteotomies was at L2 and L3, so that's where the osteotomies were originally done. The problem is that's not really where the lordosis belongs, right? This is Pierre Rousselet, who's demonstrated, that something we knew to some degree, that the lordosis really belongs at the bottom of the spine. So location matters, not just lumbar spine broadly. Probably most importantly, if you go back to Schwab's original data, what it says is that the SVA is the strongest predictor, but it only really accounts for about 22% of the effect on health status. And so we've spent 10 years trying to hone that 22% to the most complex equation we can come up with, rather than chasing after the 80%, which is, I think, probably a better plan. And then finally, this is a study from Yagi from Japan, where even people that were given good age-appropriate alignment didn't necessarily have better outcome and didn't have better standing balance, right? And that leads to the really important thought process that balance is more than alignment, right? Balance is alignment in motion. And what we measure is static alignment, and we need to be able to move away from that. So, there was a lot we learned, but we didn't really align it quite right. And now looking forward, I think we have to look at how we can sort of bridge that gap. I think it's summarized well by Jean Dubuisset, who is responsible for a lot of our thought process in deformity, and he said that good alignment is preferable in order to obtain good balance, but not sufficient. And interestingly, what he was talking about here was not adult spinal deformity, but children learning to walk. I think somehow the symmetry is good, and we see it in old people as well. Balance really is based on a lot of factors, right? It's based on central neurologic function, on conditioning, on sensory feedback. And we have a model for failure when balance is bad, and that's Parkinson's disease. When you do deformity surgery in patients with Parkinson's, they always fail. No matter where you stop your surgery, they manage to find somewhere to fail above that or below that. And I think it's reasonable to think that that same thing applies in lesser degrees of neurologic impairment. And this is a study that we did several years ago where we looked at our PJK cases and demonstrated non-mechanical comorbidities like neuropathy or myelopathy in 76% of those cases. That seemed pretty dramatic, but it was just a case series. And we followed that up by a study by Miko Ver, where we tried to do a matched control study, and we did in fact demonstrate that patients with neurologic disease and myelopathy were at significantly increased risk for PJK. So how do we get a handle on this? Well, there are a lot of factors, so you can't do every test under the sun on every patient you're going to operate on, and we were trying to get sort of a generalized measure. The one that's been found that's been best studied thus far is a study called the BEST test. It's something that's used by rehab doctors, and this is out of Scandinavia, where they demonstrated that clinical balance could be measured and tied to adult deformity. What we've worked with is something called a quantified Romberg. So the Romberg test, we put people on a force plate and try to determine their balance in a quantified fashion. This is the test where they, stand with their eyes open and their eyes closed, and you see the increase in instability with their eyes closed with that input taken away from them. This is what the tracing looks like for adult spinal deformity. You can see a much more narrow area of balance in the normals as opposed to the adult deformity patients. And this is the data demonstrating the statistical significance. So, sort of in summary, in young adults, I think that balance problems are less common. And certainly it makes sense to think about that, but I think restoring them to reasonably normal alignment, you'll often get away with that. Even if it's not exactly right for them, they can compensate. They can compensate with their hips and other areas. Once you get into middle age, it gets a bit harder, right? Then you start to have patients who have hip disease and knee disease or a little bit of neurologic dysfunction. And in those patients, I think you have to look carefully at those issues. But generally in that age group, imbalance is less of a problem, and you get away with more aggressive correction. I think in the older patients, it's more frequently a problem, and accommodation is usually necessary. I think they want less correction because that's how old people live. I think disc space is normally associated with loss of lordosis, so that's the alignment you want to restore. I think you have to worry about spinal stenosis because sometimes their positive sagittal balance is just trying to lean away from their stenosis, and just a good decompression has the potential to correct that. I think you can see that sometimes by looking at the scanogram from their MRI or their CT scan. If they restore a more normal alignment, that's probably not a fixed imbalance. And then these older patients have multiple causes of poor balance, whether it be neuropathy or cervical myelopathy or just deconditioning. So in summary, I think balance is something we need to think about. I think it's important to remember that restoring static alignment is not the fountain of youth, and you can get in a lot of trouble sort of overdoing that, and that you need to look at these patients holistically to give them the best possible outcome. So thank you very much. I appreciate your time.